All right, good evening, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Again, talking about autoimmunity and POTS tonight. This is part 2 of a multi-part series. So let me minimize Facebook. Let me go here. We're going to present from the beginning. Okay. Part 2. All right, so let me see here. Let me escape. Let me go to, okay, so that should look good. Okay, so we'll present from the beginning. Okay. So, we talked about it on Saturday relative to autoimmunity and POTS, and I didn't have the PowerPoint, so hopefully with the PowerPoint I can shed a little more light on what I was talking about and give you a little bit more of the historical background of this. And I'm happy to field any questions that you all have, because now that this information is coming about, some of you are wondering, okay, where did this autoimmune attack come from? What is autoimmune? What tests can my doctor run to further delineate this? And so I'll try and go through all of that, but we'll just kind of look at it from a glance, so to speak, as we look into this beautiful picture. We're looking at it from a distance. Okay, so just to begin, this is from Journal of the American Heart Association. I believe its publication was in 2019. The article I'm citing, I'll mention at the end of the broadcast. But here, it's just nice to see the demographics of POTS. POTS is an illness that has a female preponderance. They tend to be younger in age, as you can see here, 29 years of age approximately, with deviations of 11 years. And 94.5% of the POTS patients they examined were females. So the issue is, well, relative to diagnosis largely is based on age of presentation. What are the symptoms? Is it a male or female preponderance? So here you have largely younger females walking into doctors' offices complaining of what? Fatigue is the most common symptom, aching muscles, heart palpitations, severe headaches and migraine, shortness of breath, anxiety, joint hyperflexibility, nausea, easily bruising, cognitive issues like brain fog, irritable bowel syndrome, anemia, Raynaud's syndrome, that's where your fingers turn white, then red, then blue, or white and blue, then red, rather. Epistasis, which are bloody noses, depression, and arthralgias. Sadly, as I mentioned in the POTS and anxiety broadcast, that a large percentage of these patients who actually have POTS are mislabeled as having anxiety, or doctors referring to them as being histrionic. And you can see that, okay, look at the top 3 symptoms: fatigue, aching muscles, heart palpitations, headaches. Well, that's pretty synonymous with fibromyalgia. And you can go and watch my fibromyalgia broadcast, as I mentioned sometime recently. It's from Kelly's book of rheumatology, where they say few conditions evoke such ire referring to as anger. Few conditions evoke such ire as fibromyalgia in the back rooms of medical circles. It's something to that effect. So like in the break room of a hospital, few conditions will evoke such anger as fibromyalgia. And why is that? Because there's been a lot of misconceptions through the years, and a lot of fibromyalgia patients are young to middle-aged females who are presenting with fatigue and aching muscles and heart palpitations and headaches and brain fog and things like that. So you'll see that there's overlap between POTS symptoms and fibromyalgia. I'm not saying that POTS patients have fibromyalgia, but I'm using that as an example as to why so many of you are misdiagnosed and misunderstood. So if you want, pause the video here and you can just kind of look at these statistics, but it's pretty wild how many of you have fatigue and aching muscles and heart palpitations and headaches. So very, very, very interesting. I didn't put this article in here because it's not for public view, so to speak. But this was the first seminal article published on autoimmunity and POTS, and it dates back to 2007. So again, POTS is a relatively new illness. I think it's around, it was formally coined in the 1990s, early 90s, 1995, somewhere around there. 2007 is when the Mayo Clinic comes out and says, basically in this article, that about half of POTS patients in their experience have neuropathy, and the other half seem to have a substantial autoimmune component, basically. That's basically what they said. Now, the neuropathy that they were finding, one may argue today, may be actually due to an autoimmune neuropathy, which I'll talk about later in the broadcast. But that was the first article that came out. Now, before we get into more of the autoimmunity, in fact, maybe I'll just pause there just to make sure everybody on Facebook can hear me. And hello, hello, hello to everyone who's joining. And it looks like we're good on sound because I haven't seen any issues with that in the comments, so we'll keep rolling. Okay, we'll present what we okay, so the autonomic nervous system, as I referred to in the last video. Autonomic, think of automatic, think of involuntary. You don't have to think about digesting your food. You don't have to think about your pupils dilating when you walk into a sunny environment. You don't have to think about producing saliva when you're eating a juicy steak. These things happen automatically because they're part of our autonomic nervous system. Largely, autonomic reflexes can be mediated by the brain through subconscious areas. So if you see a lion, your physiology is going to change. Your heart's going to beat faster, your pupils are going to dilate, hair stands up on the back of your neck. You're going to release a lot of adrenaline, which will mobilize glucose for your muscles to contract better. So your brain is communicating with this automatic nervous system, which has basically two sides to it. One, the parasympathetic, is referred to as rest and digest. The sympathetic, which is coined as being the fight-flight response, or mediating fight-flight reactions. But this diagram comes from the book, The Principles of Neuroscience, and it's just a nice diagram, and I'm going to show you probably 4 or 5 from that book in chapter 47 of the latest edition, where they're showing that the brainstem and spinal cord is sending signals to what are referred to as ganglia. Ganglia are clusters of nerve cells. So we have here sympathetic and parasympathetic ganglia. And then the ganglia send signals out to the effector cells. So that may be a smooth muscle, a cell in your gastrointestinal tract. It may be a glandular cell, for secretions, for example, in your armpit. We all know that when we're stressed, we may sweat more in our axillary region. Maybe your cardiac muscle cell, so it can contract harder when you're under stress. So that's a nice example there. This is a beautiful diagram of the autonomic nervous system, and you can see here these ganglia, particularly this is referring to what's referred to as the sympathetic chain ganglia. So it's a chain of clusters of nerve cells right next to the spinal cord, whereby autonomic reflexes come out of the spinal cord to the ganglia, and then the ganglia are going to send signals to your eyes, to your lacrimal glands. How many of you have given a speech and all of a sudden, your mouth is dry, or you're going on a date and your mouth is dry and your hands are sweaty? Lung tissue is going to be affected. You may increase your bronchial or dilation or dilatation when you're under stress. Heart beating faster. Liver is going to change in its function when we're under stress. Intestines and colon are going to change. So, we tend to get stressed. What happens? We get constipated. Your bladder may be affected, and then reproduction can also be affected. The idea is that you're not going to want to think about what they refer to as copulation or reproduction when you're running from a lion. The juxtaposition of that is the parasympathetic nervous system, which is our rest and digest response, which basically sends signals to the exact same effector cells, so to speak. So your pupils are going to be affected, your submandibular and your lacrimal glands are going to be affected, your lungs, your heart. They're going to receive parasympathetic signals as well. But a lot of it, again, is mediated based on what the brain is sensing. That's very important, or what type of subconscious state your brain is in due to other circumstances. And you can see here 10, that's referring to the vagus nerve. So a lot of you read about vagal nerve stimulation and vagal activities that you can do. Well, you can see here that the vagus nerve is the main nerve innervating a lot of your organs. And down here you have your sacral parasympathetics that innervate more your bladder. I think it's the distal third of your colon and your reproductive organs. So that's the communication. But then keep in mind, zeroing in on this issue, that the sympathetic and parasympathetic nerves are going to release certain chemicals at the chain and at the effector cell. And that is uber important for you to understand as a POTS patient. Here's another nice diagram of the sympathetic chain ganglia. And they refer to it here as the paravertebral next to the vertebra sympathetic chain. And they've even done studies like in patients who have what used to be called reflex sympathetic dystrophy, also known now as complex regional pain syndrome, where they would go in and they cut the sympathetic chain ganglia, trying to relieve the fight-flight signals maybe going to an extremity, causing lack of blood flow, for example, to extremity and heightened pain. Now, this again from Principles of Neuroscience is showing you that chemicals have different receptors. So, for example, norepinephrine has these different receptors, alpha receptors and beta receptors. They have opposing actions and they're in different locations, basically. I don't think I'm going to go into the nuances of that. And you can pause and read this if you want to read more about it. Acetylcholine also has different receptors at different sites. And so when we look at this, we can see these receptors. Now, see, these receptors have they kind of look like those little, what are they? They're like little tubes you use in the pool, you know, those like long tubes that you throw out into the pool. So let's take like 5 of them together, and it's kind of going to look like a muscarinic receptor or alpha-1 adrenergic receptor. Well, these are different components to the receptor. These little, you know, what are they? The cylinder, like styrofoam tubes that you use in the pool. As you clump them together, they're different components of what are referred to as the Gcoupled receptors. And that's important also. So just going back, what we want to know is that, in essence, when you have a fight-flight reaction through the sympathetic nervous system, the sympathetic chain ganglia do have acetylcholine receptors at this point. When the sympathetic chain ganglia sends signals out to the effector cells, you are going to have effects largely through norepinephrine and a little bit through epinephrine. Here, but primarily they talk about norepinephrine. Here with the parasympathetic, you're going to have primarily the effector cells being affected by acetylcholine. So are there exceptions? Yeah, I believe it's like, I believe sweating is mediated through acetylcholine through the sympathetic nervous system, but that's the general gist. So know that acetylcholine and norepinephrine are going to be involved in these pathways. So if you're making immune cells to acetylcholine receptors, and there's different types of acetylcholine receptors, I believe these are the nicotinic, and then out here are more the muscarinic for the parasympathetic nervous system. But if you're making immune cells to those receptors, then communication from your sympathetic nervous system or your parasympathetic nervous system is not going to be appropriate. Same thing if you're making immune cells to norepinephrine receptors or adrenaline receptors, it's just easier to say it that way. Well, then the effector cells are not going to get the right signal. So now when we're talking about blood pressure, you go to stand up and your blood is accumulating down in your legs. Well, you have these natural responses through the sympathetic nervous system to communicate down to your legs to get the blood back up to your heart, and then your heart's going to beat harder and faster. Well, if you have an autoimmune response blocking that communication, guess what? Well, now your blood's going to stay down there, and you may get a compensatory hyperadrenergic state where then your adrenal medulla, the center of your adrenal gland, which is right here, is going to release a ton of adrenaline and some norepinephrine, which is going to go into your circulation and affect your heart. Or you may be making antibodies to adrenaline receptors, which is stimulating them to overreact. So that's the reality of POTS, and I really hope this makes sense. Give me some feedback. I'll jump over to Facebook here in a second, but let me know if this makes sense. Also, as I mentioned last week, because I'll go into this in a little more detail too, is the element of angiotensin 2 type 1 receptors. So if, as I mentioned last week, if you were to cut my arm and then all of a sudden I have an artery spewing blood, and I'm losing blood. What's going to happen? I'm going to have less fluid volume in my body. When I have less fluid volume in my body, the kidney is going to sense there's less blood coming through. So we're going to release what's called renin. Renin goes to your liver, which cleaves angiotensinogen and turns it into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. If you've heard of ACE inhibitors on drug commercials for blood pressure, that's what they're talking about. And then angiotensin 2 is going to float throughout your body, and it's going to have effects on constricting your blood vessels to get blood pressure up to save your life, so you have enough blood going to your heart and to your brain so that you survive. Now, with POTS, we're also finding that POTS patients make antibodies to angiotensin 2 type 1 receptors. So it's so interesting. So now that you have that perspective and you go back to, okay, now there's this large group of you walking into doctor's offices, you're young, healthy appearing females, you go to the cardiologist and they're like, what are you doing here? And you're like, well, I'm fatigued, I have aching muscles, and I have heart palpitations, I have headaches, and I have shortness of breath and anxiety. You know, their head may be spinning because you don't look like the average 65-year-old person whose body mass is, you know, above 30, and they have high cholesterol, and they've been eating 2 cheeseburgers a day for their entire life. You get the dichotomy there. So now you come into the doctor's office with all these symptoms. Now you understand, okay, this newly acknowledged condition of POTS, they just started seeing that it had an autoimmune component in 2007. Even then, they thought half were due to neuropathy. Okay, I now understand my autonomic nervous system with a general amount of knowledge and how it works. And now I can say, okay, I understand my immune system for whatever reason. Lots of times it's a viral infection. Maybe it was another factor that you've been reading about online. Maybe you went through a massive stress. Maybe you developed something like celiac disease. Nonetheless, now your immune system is targeting these muscarinic and nicotinic acetylcholine receptors, different components, or maybe components of your adrenergic receptors. And as I mentioned previously, in understanding the history of this, the first studies were not finding the majority of POTS patients to have acetylcholine receptor antibodies. But as time has gone on and as they've refined techniques, they're finding that as they look at different components of these styrofoam tubes, so to speak, of the receptor, different components of these Gcoupled receptors, they're finding that autoimmunity is like showing up in a large percentage of patients. Okay, so this comes out in 2013. Autoimmune reactive IgGs against cardiac lipid raft associated proteins in patients with POTS. So lipid rafts are basically you eat fats and they're absorbed and they go into chylomicrons and they have to be transported throughout your bloodstream to different parts of your body. So POTS patients are making antibodies to these lipid rafts. It's like, okay, so we're making antibodies to receptors, we're making antibodies to lipid rafts. This is a seminal article out of the Journal of the American Heart Association in 2014, where they said, POTS patients have elevated alpha-1 adrenergic receptor autoantibodies exerting a partial peripheral antagonist effect, resulting in a compensatory sympathoneural activation for vasoconstriction and concurrent beta adrenergic receptor mediated tachycardia, coexisting these antibodies, beta 1 and beta 2 adrenergic antibodies, agonistic autoantibodies facilitate this tachycardia. So they're finding that basically you're creating antibodies to all these different types of adrenaline receptors, alpha 1A, beta 1A, beta 2A, and so they're saying these findings may explain the increased standing plasma norepinephrine and excessive tachycardia observed in POTS patients, because POTS patients have a lot of norepinephrine. And then here's an editorial out of the Journal of Lupus. So in the Journal of Lupus, they start saying in 2016, well, there seems to be an autoimmune mechanism has been suggested as a causal mechanism in both POTS and chronic fatigue syndrome. So how many of you chronic fatigue patients actually have POTS? Has that been tested for? Has someone tested your heart rate going from a supine position when you wake up to 10 minutes later you're moving around? Does your heart rate go up 30 beats per minute? Have you had a head up tilt table test? things to consider, because they're saying due to frequent findings of autoantibodies, including antinuclear antibodies, in POTS and chronic fatigue patients. What are antinuclear antibodies? They're just a common blood test that's run by doctors, which basically surveys and says there's some form of autoimmunity going on. The vast majority of lupus patients, I think it's around 97%, have positive antinuclear antibodies. But just because you have a positive antinuclear antibody doesn't mean you have lupus. The ANA goes up with a ton of different conditions, like around 20 different conditions. Sometimes doctors will say, oh, well, this antibody can be seen in quote-unquote normal appearing middle-aged females. But maybe they had POTS, maybe they have Hashimoto's thyroiditis. So things to consider. And then here's a really interesting thing where they say, this author, Petri et al., for example, found that 74% of SLE patients, systemic lupus erythematosus patients, so SLE lupus patients with fibromyalgia or CFS have neurally mediated hypotension. So a large percentage of these lupus patients have an overlap with fibromyalgia or chronic fatigue, also have neurally mediated hypotension. So that's pretty cool. And then this is where I was talking about the angiotensin 2 type 1 receptor autoantibodies. Are saying most patients with POTS harbor this antibody activity. So that's wild. So it's like, so you have this, and then you have the, the drum roll at the end of the broadcast, which is this article, which came out 2019. Again, Journal of the American Heart Association, postural orthostatic tachycardia is associated with elevated Gproteincoupled receptor antibodies. So I talked about the acetylcholine and the adrenergic receptors being Gproteincoupled receptors, the foam, styrofoam things from the pool clumped together. And here they basically said that 89% of POTS patients had adrenergic alpha-1 receptor antibodies. 89%. That's like 90% of you are confirmed as having autoimmunity to an adrenergic receptor. And 53% had autoimmunity to the muscarinic acetylcholine M4 receptor. So, and then they said, surprisingly, elevations of muscarinic receptor antibodies appeared to be dependent upon elevation of autoantibodies against the A1 adrenergic receptor. So it's like once you have antibodies to the adrenergic receptor, then you're going to have a much higher chance of having antibodies to acetylcholine receptor. Their conclusion, our observations provide further evidence that in most cases, POTS patients have at least one elevated Gproteincoupled adrenergic autoantibody. In some cases, both adrenergic and muscarinic autoantibodies, supporting the hypothesis that POTS may be an autoimmune disorder. I mean, we're talking 90%, folks. And you go back up, and here they found that 7 of the patients in the study, I can't remember how many people were in the study, there's 55 patients in the study, like 7 of them had antibodies to everything, which is so interesting. So it's antibodies to everything, antibodies to lipid rafts, antibodies to angiotensin 2 type 1 receptor. You have antibodies to almost every domain of these acetylcholine receptors and the beta 1 and beta 2, alpha 1 and alpha 2 adrenergic receptors. This is wild. And so this is really showing huge evidence for the autoimmunity in POTS. And then how much of what we thought was neuropathy was in actuality autoimmunity to these receptors, which maybe then was affecting neuropathy. We don't know. But it leads one to surmise based on this evidence. So it's pretty significant. And if you're the POTS patient, what lab tests can you talk to your doctor about? You can be screened for antinuclear antibodies. You can be screened for Hashimoto's thyroiditis, screened for celiac disease, screened for, maybe you get screened for antiphospholipid syndrome. I read an article on that. So you're going to get generalized autoimmune testing. And maybe it comes back positive, maybe it doesn't, but know that the research is saying 89% of POTS, based on this newest study from the Journal of the American Heart Association, 89% of POTS patients have autoimmunity to the pathways affecting their symptoms. So, pool noodles. There we go. Thank you. Pool noodles. So what can you do for these symptoms is one of the questions. Well, that'll be my last broadcast, but basically in my experience, you want to look at foods, because what happens is that there's this dysregulation between the gastrointestinal tract and the hormones. So POTS is a hyperadrenergic condition. And so now you have a lot of adrenaline. Again, what does a lot of adrenaline do? It's going to slow down gastrointestinal motility. That can facilitate the wrong bacteria growing in your small intestines and your colon, which then can lead to breakdown of your gastrointestinal barrier, which can further promote autoimmunity. So that's one area I would really look at first. Also, I would look at what the Mayo Clinic is talking about in terms of graded exercise. You may want to look at that. I do these procedures with my patients. I can't really tell you exactly what to do, but I'd say if you're curious, look at what the Mayo Clinic is recommending in terms of graded exercise for POTS patients. And I'd really look at the food you're eating, and really look at the gastrointestinal microbiome, and really look at strategies for how you can get blood volume back up to your brain. You can work with a cardiologist who knows about POTS. More cardiologists now are using different alpha and beta blockers. There's new information coming out about medications typically used for a condition called myasthenia gravis, which affect acetylcholine levels, now being used for POTS patients, and some POTS patients are reporting a lot of success with that. It's all kind of in how you want to skin the cat, so to speak. If you want to take a medication-based approach, I'd find a cardiologist who's very up-to-date on POTS. If you don't want a medication approach, then you want to find somebody who's pretty abreast of the POTS literature and knows how to handle it functionally. And so yeah, I think that's pretty much it. So let me know what you think, any other questions you have, and I think that pretty well summarizes it. So we'll go from there. Be back on Saturday. Have a great Wednesday night, everyone, and talk to you soon.